Good afternoon, everyone. Hopefully, you guys all just finished your first quiz. This video here is Chapter 4, the healthcare facility. The reason we're doing this one by video is because you guys have your quiz and we got a couple more chapters to cover this week. So, this is to kind of knock this one out and get it out of the way. We're going to kind of generally go over kind of how the hospitals are set up and more specifically, how the ORs themselves are set up and why they're set up that way. Some of the standards and recommendations for your design of your operating room um, is based on a few different factors. There's a bunch of different regulatory agencies and people that come in and they're concerned with, like, patient safety and employee safety. That'll be like your employee safety would be like OSHA, things like that. Um, Infection control, like actual structural, walls and things like that, and be able to hold things up and um, feeding in all the lines of like oxygen and CO2 and nitrous and things like that that have to be pumped through the walls, and then you have to set up, all the different filtration systems as far as like the air and the airflows and things like that. So a lot of different companies or a lot of different regulatory bodies and things like that in this. You have the people who are involved with infection control, the quality people. Those are more for your uh, like safety and things like that. You got architects in there, the EPA, right, to make sure that we have correct disposal and things like that, and that we're safely handling the medications and chemicals and things like that that are necessary inside of a hospital. And then, of course, OSHA. OSHA, if you're a business of any kind and you have employees, you deal with OSHA. OSHA is the big safety body that takes care of all of that. Accreditation for hospitals, institutions. Now, not only do uh, schools, colleges, and secondary education think that have to go through an accreditation process, but so do hospitals. And usually it's by the TJC or the Joint Commission. They come in and they check through like all your paperworks and your safety stuff, and they'll talk to the staff and ask them questions, all that just to make sure that the facility is compliant with what they need to be compliant with, and that patients are safe, workers are safe, that all the correct procedures and everything are being followed. The Joint Commission can actually come in and shut down a hospital if you don't meet all the requirements. So then, if your hospital is shut down, you can't accept patients into the ER. You can't do any surgeries until all of that has been corrected and they come back out and check off on it. So the Joint Commission has a lot of power in that kind of setting. Some of the reasonings or principles behind the way we design operating rooms, the way we do. Uh, Sorry, I'm going to pause this for just a second. Okay, sorry about that. Uh, but okay, sorry. The Some of the reasonings here, why we design our operating rooms the way we do, is for these reasons you see listed here, right? Infection control, environmental safety. Sorry, hang on just 1 second. Sorry, but I guess there was a little bit of confusion. I sent out an email just before I started this, giving you guys the link to this meeting site, and I think people are thinking that they had to get in. So anyway, but we do this because, we're trying to prevent the spread of any kind of infection, right? The spread of microbes. We're trying to make it safe to, wheel patients in and out, and for, employees and stuff to be able to move around and do their job. And then, also helping to make it efficient, right? So that you can go from one task to another without having to waste a lot of time and stuff like that. Some departments, they keep all of their equipment, instrumentation, and supplies up in the operating room itself. They have different storage rooms and things like that. They can put that stuff in. Other places, they keep all their stuff down in SPD, and then they have to have it brought up. But you can see how it may take a little bit more time to call downstairs for something and then have to wait for somebody to bring it to you, rather than just being able to go and get it out of a room or something like that elsewhere in the same department. But as far as infection control goes, right, we need a physical separation of areas that are considered to be clean and areas that are considered to be contaminated, because we do deal with a lot of bloodborne pathogens, microbes, all that, because we are doing surgery, right? So the places where we're doing the actual surgery, we need those to be our clean areas, which is why we do a lot of high level disinfection. We do our turnovers, all of that, in order to go from one case to the next, right? And then in the contaminated areas, that's where we take all of our dirty stuff to get cleaned, and that's decontamination done in SPD, right? We take all of our dirty instrumentation, and that's where we actually take it and clean it, right? We try to contain as much as we can, and then confine, like for decon or decontamination, where we take our dirty stuff. That room is always considered dirty, so we just confine the dirty to that room and try to contain it in there. We try to keep traffic flow to a minimum, right? Because anytime you're walking in and out of places, every time you're opening a door, you're causing airflow change. And that's going to kind of stir up microbes that were just dormant or laying on a surface. As soon as you have a wind come around, and now it pushes them up into the air, and now they're floating around in the air. So that's why we try to keep the traffic low, and we also try to keep the number of people in the room to a minimum, right? We try to keep it to the minimum number of people we need to complete that procedure. And then the separation of clean and contaminated areas is preventing a cross contamination. That means you're taking, like, let's say you were doing a procedure in room 1, and you're taking your dirty instruments over to decon, but you cut through room 2 with your dirty instruments. Now, whatever microbes were on that stuff can now potentially get into the air of room 2. And then if they're doing a patient at that same time, or maybe they're about to do a case in there, then now you potentially have a cross contamination that can happen. So that's why we have a set way of doing and how we move dirty instrumentation and try to keep things separate. Environmentally, right, this is our electrical outlets, the gases we use, the lights in the OR, the light box for your laparoscopy towers, things like that. If it's like a piece of equipment, your Bovie machine, the anesthesia machine, the OR table itself, something that has circuitry or gas lines, things like that. That's all considered in that environmental. Right? So we have to, yearly, all of our equipment gets checked by our maintenance guys and checked off that it was checked. We go through great lengths, and then every day when we come in, whatever room we're in, before we even start opening our supplies and instruments and all that stuff, we double check that all the equipment we have in the room is functioning properly. We'll turn them on, test them, give them like a little test run, whatever, just to make sure that they work, because we don't want to have to, in the middle of the case, now we have to correct something that's not working. So, and then efficiency, right? That's keeping our instruments close, right? Having the day's cases for that particular room kind of lined up outside the room so that you don't have to go walking real far. We do the same thing in the OR. Whenever we lay our stuff out and we start to open, we always open at the back table first and then we move out. And we always try to make our movements and everything that we do very efficient. We're not trying to waste a lot of movement. You'll see it when we go to set up and things like that. The tendency early on for students is you touch a lot of stuff on your field a lot of times, right? Because you're not 100% sure where everything goes, right? You're not 100% comfortable with doing the task yet. So there's a lot of extra touching. You'll take one thing and move it to this spot and then start working, setting up something here. And then you'll go back and now you need to move that again because now you need to set up something in that spot. So you guys will learn this. And it takes a lot of practice to get this down because it's something that you have to become comfortable with. And you have to, so doing it just once or twice, you start to feel, okay, yeah, I got that down, but you need to be able to do it without even thinking about it. And that's where the repetition comes in of doing it over and over again. We're trying to minimize that physical effort, that having to walk back and forth between something. So like if you're opening with supplies sitting on your case cart, you don't want the case cart on the opposite side of the room from where you're opening at, because then you open one thing, you throw away that trash, and now you've got to walk over back to the cart to grab something else. You want to bring that close to you. The same is true for the trash can. You don't want to open something and then I have to go walk over to the trash can, throw that trash item away, and now come back to start opening more stuff. You bring your case cart and the trash can near you. So then you open something, throw it away, grab the next thing. So you're not moving all over the place. Right? We keep our, the materials and supplies that we use most often and may need to replenish during the middle of a case, like sponges, suture, things like that. Maybe even some extra instrumentation. We try to keep those in the OR department, so it's easy to go and get, and you don't have to wait a whole lot of time. Thing to remember or to take note of is that we, as the tech and the nurses too and stuff, we're hourly employees. So for us and our mindset, it doesn't matter how many cases we do in a day because we just need our 8 hours or 10 or 12, whatever your shift happens to be. For the surgeon, they're not on a time clock. And the anesthesiologist as well. They get paid based on the number of cases that they do. So they want to do as many cases in a day as possible. Kind of clash there, right? Because we're hourly. We want to do the least amount of work but get paid the most, right? Be able to work our full 8 hours but only maybe do 1 or 2 cases. Whereas the surgeon, they want to do 5 or 6 cases in that same 8-hour period. So that's where our turnover times have to be 20 minutes. And by turnover time, that's the time from when a patient leaves the operating room to the time that the next patient enters. So you get 20 minutes to clean the room, open your stuff, and reset up and be ready. So, and that's because surgeons get paid by quantity of cases and quality as well, in terms of, if they have like infections and complications and things like that. But Majority of the time, it's quantity, number of cases. So uh, that's where we come in and being able to facilitate this efficiency and getting things moving quickly. And that's why we design and do the things that we do in terms of keeping materials and instrumentation, everything close at hand. Your traffic patterns, right? We try to control, you know, where people move in the operating room, right? You'll see some floor plans in the chapter. One of the more common is what's called a racetrack. It's where you have an outer hall that goes around the outside of all the operating rooms. And then you have a big central core in the middle of all the operating rooms. So the ORs have two doors. There's a main door that accesses that outer hall. That's how patients come in and out. And then there's another door inside the OR itself that leads to the inner core where we keep all of our supplies and instrumentation and equipment and things that we need so that we can just go in there and get it. Um, those inner cores, they also have, you don't have to cut through the ORs. It's actually not recommended to cut through an operating room, whether or not there's a case going on in there or not, so that we keep down the amount of microbes that we're introducing into those environments. But the operating room or the entire department also gets broken down into three areas, right? You have your restricted areas, your semi-restricted, and your non-restricted areas. This actually should say non-restricted on that first one. But for your non-restricted areas, these are the areas that are considered like not necessarily not clean, but it's where you can wear like your street clothes, right? It's where you can walk through in like your suit or your jeans or whatever. You do not have to have scrubs on and like a hat and mask and all that stuff in order to enter into a non-restricted area. Now, non-restricted areas would be like the front desk, the locker room. Obviously, the locker room, right? You got to walk in there in your street clothes in order to change into scrubs. Um, anything that is on the, I guess, non-clean side of the red line, right? Because all operating rooms are operating or OR departments, excuse me, because the department is different than an operating room, right? The department is all of the operating rooms together. The operating room itself is just one single OR suite. But so the non-restricted, that red line is the marker. So it'll be on the floor, along the wall. So just visually, as soon as you cross this line, now this is the point where you're now in a semi-restricted area, where you have to have on your scrub suit, you have to have on a hat. You don't necessarily have to have a mask yet for a semi-restricted area because you're just in like the outer halls, right? Or in the OR lounge, right? Is also considered semi-restricted. But once you enter into like the substerile area, which is a little like kind of closet area between operating rooms, it's usually where you're going to find like your flash sterilizers, maybe some of your more specific supplies and everything to the surgeries that you typically do in that room. Um, but once you enter into that substerile area or into the OR itself, now you're in a restricted area where, yes, you have to have on your scrub suit, you have to have on a hat, but now you also have to have on a mask and like eye protection. The it says signs must be visible, right? It's that red red line. That red line lets you know, hey, as soon as I pass here, I better have on all my stuff. And then you got to watch, these traffic patterns. Sometimes I've seen it before where, I come out of one of the ORs, I'm in that outer hall, and then I see somebody walking around in just regular clothes, no scrubs on. And I'm like, oh, then you have to approach them. I'm sorry, are you lost? You need help because you need to get them out of that semi-restricted area. They're contaminating the area there just by being there because of all the microbes and stuff on their clothes. And it's why we change into scrubs, right? It's for that infection control part. Some of the other designs of OR, the racetrack is usually the more common, but this is that racetrack style I was talking about, right? You have like an outer hall here, and then all the rooms are lined up along it, and then you've got like the centralized workroom, maybe like an office or something like that. Another style is you have like these kind of cores like this, where the ORs are on the outsides, and then everything is kind of centralized here. The other one is the ORs line the middle, and the outer hall goes around the outside. But in your textbook, that's figure 4-2. What do you think are some of the benefits? Just kind of some food for thought for you guys. Obviously, you can't answer me. But what do you think of these two designs? What would you think are maybe some of the benefits, to these designs, and what would be some of the kind of like liabilities, what the problems with it? Everything, nothing is a perfect design. You're going to run into some issues here and there, but some things work better for some places, depending on how their flow goes. We all just kind of make it work. Um, yeah, we talked about these, right? The unrestricted or non-restricted areas, semi-restricted, and then your restricted areas. Another way to think about it is those are your sterile areas. That's the operating room itself, or the like sub-sterile areas where you have to have your mask on now. Those are considered your sterile areas, right? Your locker rooms, that's your non-restricted because you can walk. Most of the time you're in there in your what's called civilian clothes. And for those military members that I have, you guys know what civvies are. But we're just trying to prevent the spread of disease with these patterns and clothes and everything that we wear and stuff like that. So that unrestricted or non-restricted area, that's that transitional area, right? That's your where you're changing, right? That's your locker room, right? Can also be the lounge. Sometimes you have medical device reps that'll come in the lounge, first and like drop off food and things like that, and they're not in their scrubs. You can actually access the OR lounge just like you access the locker room. You're supposed to be able to go in there without having to wear your scrubs. A lot of times the lounge is connected to the locker rooms. You can access the locker rooms through the lounge for that reason. That semi-restricted area, right? These are your patient holding areas, pre-op, post-op, right? Maybe some of the offices inside the surgical department itself, right? You can have people in there in both civilian clothes and scrubs. Your corridors, right, around the OR suites. But in this area, there's that red line, right, where you're having to put on your hat. Usually, sometimes in these places, like these offices and things like that, you don't necessarily have to wear your hat because you're not across that red line. But it's still considered kind of semi-restricted because you can have a mixture of both regular clothed people and scrub people. Pause. Sorry, just for 1 second. Sorry about that. That was Mr. Ortiz. Uh, but in these areas here, like in the corridors, if you're near the scrub sinks or if you're in one of the equipment or supply rooms, then you definitely have to have your hat on at the very minimum in the semi-restricted area. Also with your scrub suit. But there's other places, utility workrooms, central processing, um, because both in the decon area and where you're reassembling and sterilizing, you don't have to wear a mask, but you do have to have on at least a hat and your scrub suit. Anesthesia workroom, post-op, right? We already said that one. Unless this anesthesia workroom is behind the red line, and then now you're in. Well, no, I'm sorry, you're still in a semi-restricted area because this wouldn't be in the OR itself. So yes, this is still just hat and scrubs. And then in your sterile or restricted area, this is where you need to have your mask on. So you're going to have scrub suit, hat, mask at a minimum. If you don't have OR dedicated shoes on, then this is where you also be wearing in the restricted and semi-restricted area is where you'd be wearing your shoe covers. Operating room equipment and furniture. Right? This is the OR table itself here. Right? It's adjustable, which means you can change it into different positions. You can, tilt it left or right. You can move the head up or head down. You can raise the table up. You can lower the table down. All kinds of different things. It's got these pads here on it. You guys will see more of this in the lab. It also has arm boards that you can detach from the table itself. That's places to rest the arms. You have like leg holders, like stirrups and things like that that can attach to the table. The table also has like a kind of like a space under this padding where you can slide a X-ray cassette in there. So if you need to take an X-ray of the patient at any point during the procedure, a flat X-ray, what's called a flat plate X-ray, you can slide that cassette right into that space and put it in place for where you need to take your picture. Most of the time, if you're doing X-rays in the OR, though, you're going to be using it's called the C-arm, and we'll talk about that much later. Some of the other furniture, right, is your back table. Right, your back table is your main working space. Normally what gets placed on the back table is your pack or your back table cover, right? When you're first laying everything out. But, it's going to hold the instruments you use for surgery. It's going to be covered with these sterile drapes. Usually the back table comes up to about waist height, different depending on how tall you are, how short you are. But there's your OR bed, right? This is an arm board, and this is the controller that can adjust this bed, that can make it. And then you can see there's this space right in here, right? All the way along this, and that's where that cassette cover can slide down and fit into that space, and you can get your image that you need to get. Here's a back table. Right? You can have really tall ones. You guys see them, a couple in the lab. You can even have ones that are what are called double decker, where you've got this space here, and then you also have some more poles coming up, and then you have another shelf up above it. And there's a special drape that they use to drape that table off with and stuff like that. But you can be doing a surgical procedure in which you need all that space because you're going to have all that instrumentation. This here is what's called a kick bucket. This is where you're going to drop your soiled laps and Ratex, your sponges from the field. You throw them into this kick bucket, and the nurse comes over and takes them out and organizes them for your count. Right? The reason that it's called a kick bucket is that you never pick this up with your hands and move it. There's a reason it's on wheels and it's got this kind of uh, guard here. Is you really do just kick it. You're just going to kind of kick it with your feet and play some soccer to get it into the position where you want it after you've pulled all your Mayo stand and your back table and your ring stand up to the field when you're doing surgery. So that way the bucket's close and you can just drop stuff. You're not trying to throw a bloody sponge across the room to get it into the bucket. And then you have what over here is a single ring stand. And this is where you put like your basin. And then you also have a double ring stand. Looks just like the single, only you're going to add another one here next to it, and it's all connected. You'll see it in the lab. But this is where you put your basins, is in your ring stands. Right? You can also use the double ring stand to put your instrument tray on, the hard container. So when you open the lid, it has something to stable this to rest on while you go and scrub your hands, and then you can come over and pull the actual instruments out of it afterwards. There are some special rooms in the operating room that are deemed as these specific rooms. You have a cysto or cystoscopy room. The bed in that room cannot be removed. It is fixed to the floor, and it also has a X-ray C-arm attached to it. So you make that specifically all the rooms that you do cystoscopy in. You do all your urology type procedures in there. Interventional radiology, same thing. They have a very special bed with a C-arm attached to it that does not leave the room. It is fixed to that room. This is where they do like it's like your cath labs, things like that, where you're doing vascular type procedures. Nuclear med, same kind of reasoning, and also you don't want these like isotopes and potential radiation type medicines being spread around the whole hospital. So that's why you keep them all in one special area. And then as far as like your emergency department, obviously ER has its own special. But what this refers to in the operating room is some places that do like trauma surgeries and things like that. They have one room that is designated as their trauma room. And it's usually for these facilities like level 1 trauma centers, there is an elevator that goes straight from the ER to the operating room, and whatever room is closest to that elevator is usually the one that's designated as the trauma room. So that if something's going on down in the ER and they need to bring that patient to the OR immediately, they just use those elevators. As soon as they come off that elevator, they're headed to that first room. It's all about that timing, and because in a trauma situation, it's life or death. So the less time we have, roaming this patient around the hospital, the better. Yes. I was just reading the bottom here about making sure I hit that. Yeah, these rooms are specifically designed and have the equipment and supplies necessary to do those specific procedures in those rooms. Airflow, right? Very, very important in the operating room because we don't want those microbes just floating around in the air and becoming droplets or dropping down into an open incision or something like that, causing an infection. The airflow in the operating room is what's known as laminar airflow, or it's a positive airflow. What that means is that we're actually pumping air into the OR at such a rate that it's whatever air is in this room is being forced out. So we're constantly pushing air in to force old air out. And every hour we have about 15 to 20 air exchanges, which means that, so let's say we start right now, the air that is in the room I'm in my office here, the air that's in here, in 1 hour, a minimum of 15 times, there will be all brand new air in here. So that means once every 4 minutes, the same molecule of oxygen or of air that was in here 4 minutes ago is no longer here. There is a new one that has replaced it. All of them that were here 4 minutes ago are all gone, and we have all new ones. Right? They definitely use HEPA filters to try and filter out any, foreign body microbes, anything like that. That's just going to be in the air, traveling through the vent, and dust and things like that, so that we're getting the cleanest air into the operating room. The reason that this is important is that if the air handler, this fan, ever malfunctions or shuts down, and now you no longer have a positive airflow going through into the operating room, you cannot do procedures in that OR. And if you're in the middle of a case, you finish whatever case you're doing, and then all other cases after that were to follow are now on hold until they can get the air handlers back online. But remember these numbers, 15 to 20 per hour, once every 4 minutes, or once every 3 to 4 minutes. We're having an air exchange by using laminar airflow or positive pressure. We're always pumping air into that room so it pushes out the old air. Might be a test question. Temperature and lighting, humidity. These are temperature and humidity are important. That the humidity in a specific operating room has to be between 30 and 60%. Too high, or anything over 60%, and you're going to start having condensation on the walls and on surfaces. Right? There's too much moisture in the air. What do microbes love? Moisture. Right? It's one of the things that they want. So that now you're going to help microbes grow. Humidity that's too low, below 30%, is going to cause a buildup of like static electricity, electric charges. And a lot of you may not know this, being here in Florida, but in other parts of the country, when it gets cold, right, during wintertime and things like that, you actually go out and you can shock yourself if you build up enough kind of static electricity just by touching your car when it's cold. So what can happen in the OR is that when you use the Bovie machine to stop bleeding, you can have arcing of that electrical current just in the air if the humidity is too low. Temperature. The operating room is to be between 68 degrees and 73 degrees Fahrenheit, because anything beyond that, and now it becomes very difficult to control humidity. There are some exceptions to this temperature. Right? Sometimes we turn it down colder than that. If we are doing like an orthopedic, a total joint replacement where we're going to be using bone cement. Bone cement comes as a powder and a liquid, and you mix them together, and then it turns into a putty and hardens over time. It's usually pretty quick. But the colder it is in the room, the longer it takes to harden. And you kind of want it to take a little while to harden because you have to put it on the bones and on the implants, and then you have to get those implants into position and lined up right and all that. And if it's hardening too fast on you, you may not get that implant into the right position before it hardens. And then now you've got to chisel it back out and start all over. Um, and then there's other times where we turn the temperature above 73 degrees, and those are typically for your pediatric patients and the geriatric patients, people who can't regulate their own body temperature very efficiently. So we turn the room temperature up in order to accommodate those patients because they typically lose heat a lot faster than a regular kind of adult. Um, your lighting, that's your overhead lights, right? You can even do like headlights, like a big contraption that they actually strap to their head, and then it's got a cord that comes off and plugs into a box, and then they've got the light on the front here. Um, you have all your, different anesthesia type gases, oxygen, air, nitrous oxide, nitrogen. Some of it we use to power some of the equipment that we have, things like that. Then you have like either your suction tree, which you'll see in the lab. I'll point that out to you guys, or you have like a suction machine, but some kind of suction. Your Bovie, all different kinds of equipment in the OR that we're going to talk about at great length. Um, these are all kind of your like work areas that aren't the actual operating room itself. All of these are going to kind of support that OR, right? You have the surgical office where you can either have like your managers in there, your educators, things like that. Then you also have like your front desk area where you're going to find the big magnet board that's got all of the cases for the entire department for the day, just kind of broken down by room number and then who's assigned to what, things like that. You've got your locker room lounge. Usually those are together. You've got pre-op holding. And this is where they're going to do all those tests and fill out all the forms, the consents, and verify these patients and make sure of allergies and all that stuff before we bring them into the OR. Start the IV, things that do the shaving if we need to, stuff like that. Right? You got your scrub sinks. This is where you're going to do your scrub to scrub in to come into the room. You have a sub-sterile room that's usually either going to house the flash sterilizer or the um, like any other little equipment, supplies, things like that you may need for certain procedures. Then you also have like your sterile instrument room where you're actually storing the sterile supplies and instrumentation. You also have a storage room for the equipment because the equipment itself isn't considered sterile, right? It's because all the stuff is off. It's the things that you plug into your Bovie machines, your headlights, your harmonic scalpels, your camera, your light source, all that kind of stuff. um, then you've got your decon area. You've got, and this will be an SPD. Excuse me. You have your decon area, and that's separated usually by the washer sterilizers and a wall. And then on the other side of those is your clean processing area where you're going to reassemble all your tools and stuff and then get it ready to be re-sterilized. Then anesthesia has their own department and offices, just usually in conjunction with the OR department. Then you have PACU. PACU and pre-op are usually two sides of the same coin, right? It's going to be in the same area, just one half of it is for pre-op, and the other half is for PACU. Then you have your surgery waiting area. That's where the family is going to be waiting. And then if you have an integrated operating room system, this means that it's like a smart OR, right? It's you have booms coming from the ceiling that's got all your camera and light cord and Bovie equipment and things like that, and that can be moved around, and it's just connected to the ceiling. You have the ability to make the windows kind of turn frosted so that people can't see in if you're working on like a VIP patient or you're doing a procedure where you're trying to protect the patient's privacy. Maybe they're up in stirrups or something like that, or they're laying like in jackknife position or something like that. And then you can just frost those windows out instead of having to hang something over to block the window. or you have like a camera in the room that's keeping an eye on everything. Those are your kind of integrated operating rooms. They're smart ORs. So some of the different departments within the hospital and the healthcare facility, and kind of what they do. Right? You got pathology. Pathology is the study of disease. So they're looking at all the tissues and blood and fluids and everything that we take out of patients. They're the ones who are looking at it and kind of giving a diagnosis as to what they find with it. Right. Nuclear med and interventional radiology. They're doing procedures in their departments on like vessels and nuclear meds. Maybe putting in some radiation therapies and things like that. Right? Infection control is making sure that we're cleaning the way we're supposed to be cleaning, and not just in the OR, but throughout the whole hospital, right? And they're making sure that those traffic patterns of, if you're taking a specimen down to the morgue, or that you're actually following the path. You're not walking in some of the main hallways where you're going to find patient families and things like that with like, an amputated leg or something, in a bag. Biomedical engineering. They're the guys, you'll hear them referred to as biomed. They're the guys that check all of our electrical equipment and make sure it's functioning properly and doing what it's supposed to be doing. And they do like those annual checks. They're also the people that you have to call if you're bringing in an outside piece of equipment, whether or not you used it just the day before or not, because as soon as it leaves the hospital, they're no longer responsible for it. So every time it comes in, you have to call biomed. They have to come and test it and check it out and give it the seal of approval before you can actually use that piece of equipment in the operating room. Materials management. These are the people who do all the ordering for all the supplies for the hospital. So whether it be a Foley that a nurse needs up in ICU, or some kind of dressing that they need over in interventional radiology, or sutures that we need in the OR, whatever it is, whatever the hospital needs, materials management, they're the people who do all the ordering and like the storing of these items until we take them out and out of their boxes and stuff like that and deliver them to all the different departments and things like that. Central supply, they work real close with materials management. Central supply is kind of the people who distribute all of that stuff to whatever department needs it in the hospital. Things like that. They're the ones who maintain all the shelves and things like that. But central supply can also be, they serve kind of a dual role function. Not only are they taking care of the rest of the hospital, but they're doing all the sterilizing and cleaning of the instrumentation for the operating room and keeping all of the supplies for the OR too. So the central supply is kind of a main hub for the whole hospital. Without a central supply, nothing really works well. There's a pharmacy, and this is the inpatient pharmacy. So this particular pharmacy for that's in a hospital is for the patients who are in the hospital. So it's not like we can go and get, and they're the ones who are going to restock all of the meds and things that we need for the OR and for like anesthesia and stuff like that. We have to put in the order with pharmacy, and then they're the ones who comes up and they fill like our Pyxis machines, and deliver the medications that anesthesia uses and things like that. They're also the ones who check over the code cards and verify that all the medication that's in there is correct and everything like that. And then they put the lock on the outside to make sure nobody gets into it and steals any of that stuff. And then the lab. So pathology is doing all the testing on tissue. The lab is the one that's doing it all on the fluids. Right? They're testing your blood, doing a complete blood count, CBC, or a chem panel, checking your metabolic state. Right? Checking if you've had a heart attack, they're checking troponin levels. They're checking your blood sugar if you've got diabetes, all that kind of stuff. If they're drawing something out of you, the lab is the one that's checking it. Blood bank. The pathology lab blood bank. They're all in microbiology. They're all in the same kind of department area. These are like subsections of those departments. The blood bank, these are the people that we call for the OR when we need to give blood to a patient. So then we call down there and get like the donor bags and things like that. Risk management, these are the people who walk around and do like quality assurance. Right? They're looking to make sure that, if there's like somebody just mopped somewhere, there's a wet floor sign up. If there's a piece of carpet or tile on the floor or something like that that's got like a hole, it's a possible tripping hazard or something like that. Risk management is going around and doing all these assessments all the time, checking out stuff. Is that a danger? Is this a danger? Could we possibly get sued from this? All of that, and they get involved when mistakes happen too, right? They're preventative, but they're also there if something were to happen, like if we accidentally cut off the wrong leg or something like that. Now, risk management is going to come involved and see what protocols we have set up to kind of avoid these risks, and did we follow those? And then what kind of training, what kind of remediation do we need, and things like that to be able to get things corrected. Right? As far as the communication system, this is like your phone lines, and like if you have overhead intercom systems, or if they use walkie-talkies, things like that. There is a central place in the hospital where they kind of take care of the communications. Right? You also have it for like your like community-wide type events, like if something were to happen, a plane crash or terrorist attack or something like that. These communication systems also come into line on that for the emergency response. Then you have a medical records department, right? They're the people who keep track of everything that we've done to every patient since the hospital opened, right? Because it's necessary that we have to keep record of all of that, right? But not only so that we can better provide care to the patient, but also to protect ourselves from any kind of litigation or anything too, right? Facilities maintenance, these are the guys that go around and fix stuff. When risk management finds that tile floor or the carpet or something like that, they talk to facilities. They're also like our plumbers and like electricians and wall fixers and windows and all that kind of stuff. Temperature, right? If we're having an issue with the air handlers and stuff like that, they're the guys we call is facilities maintenance. There are our mechanics, basically. Environmental services, this is housekeeping. So these are the people that go in and clean like a patient's room up on the floor after they've been discharged. Or they do, cleaning while they're still there too. But we also have some housekeeping in the operating room that help us turn over the rooms. Things like that. Security. Sometimes you need security, especially in labor and delivery. Right? It's not uncommon for a dad to realize that he's not really the father of that baby. And emotions run high in that situation, right? You're all gearing up thinking that you're going to be a dad. You've been spending months and months, kind of preparing yourself mentally and everything and getting into that right, frame of mind. And the baby's born and you take one look at the baby and you're like, I know for a fact that's not my baby. And now you were super excited and now you're super mad, right? Because you've just been lied to and all this. So things can happen. So you're going to need security available to kind of help de-escalate situations and things like that. Same thing, it can happen in the ER where someone got dropped off from a gang shooting. And they got him in the ER, they're working on him, and suddenly the rival gang wants to come in and make sure he's finished off. Security, need some security. And then nutritional services, this cafeteria, right? These are the people who feed the patients. So you have to have a nutritionist, all that kind of stuff, so that you're getting the right kind of foods to the right kind of patients. Right? And heal more efficiently and quicker. Then you have the administrative the actual administration of healthcare. Right, you have your primary healthcare. That's like your hospital, and you can have either an inpatient, somebody who's going to stay overnight, or you can have an outpatient facility where no one stays overnight. The longest you can do is what they call a 23-hour observation. So the patient stays there for up to 23 hours, but at the 23rd hour, they either have to be moved to inpatient status, and if you don't have any inpatient availability at your facility, then they have to be shipped to a hospital that does, or at 23 hours there, or even before 23 hours, the patient is well enough to go ahead and be released to like a family member or something like that, and be sent home. Sorry about that. Okay. Uh, but a lot of that inpatient or outpatient is going to be, it's going to rest on the diagnosis that the doctor gives the patient. Right? Is it something that they need that treatment, so they have to be an inpatient overnight, or is it something simple? We're doing like a breast biopsy, and they don't have to stay overnight; they can go home that same day. Um, but these satellite facilities, sorry, down here you see in the notes section, and I highly recommend that for any of these PowerPoints, and pay particular attention into this notes section. There's going to be some key little uh, hints and tidbits and things like that that are going to be in there that may help you on a quiz or a test. But an example of a satellite facility would be like a surgery center or an urgent care or doctor's office, something like that. Something somewhere where a patient can receive some treatment, but they're not going to receive full hospital treatment. They won't be able to stay the night. Healthcare financing, right? This is how in healthcare the doctors and the hospitals and things, this is how they make money, right? You can either have Medicaid or Medicare. What's the difference between the two? Does anyone know? Medicaid is usually a state-run system, while Medicare is federally run. Sorry, hang on just one second. Okay, yeah, so Medicaid is usually state-run, Medicare is federal. Right? Then in your private insurances, right, you either have a PPO or an HMO, right? PPO tends to be a little more expensive and like very specific list of providers and everything like that. And an HMO is a little bit more broad, a little bit less expensive uh, because you have a bigger network of people, usually in the HMO. Um, some of the ways that they get paid, that the surgeon will get paid or anesthesia gets paid, is it's usually based off of the patient's diagnosis, right? Or whatever procedure they happen to be doing, right? There is a big book called the ICD book, the International Classification of Diseases. ICD 10, I believe, is the newest version of it, like, the 10th time that it's come out. But it's a pretty thick book, and it has the list of all the possible diagnoses and issues, and it's got a little code that's associated with it, and that's the code that you enter into the paperwork, and then whatever code that is, that matches up to a dollar amount, and based on whether it's Medicare, Medicaid, or it's the private insurance. And they have like a whole chart, like the first list is Medicaid, the next one is Medicare next to it, and then if you have Cigna insurance or Blue Cross or whatever, and then off to the side is the list of all the procedures. And let's say you're taking out somebody's appendix, laparoscopic appendectomy. Well, for Medicaid, the doctor gets reimbursed like $35. I'm making that up. I don't know exactly. For Medicare, it's around the same, say $40, right? But then for, say, Cigna insurance, the surgeon's going to get reimbursed $500. And for Blue Cross, it's $200. So you see how that's how that works. It's for anyone who's ever been like a mechanic, or knows anyone who works like in a mechanic shop and everything. They have a very similar book where it says, okay, we need to replace the gaskets on this V8, uh, engine or whatever, and they look that up in the book, and it says, okay, this is the number of hours, say 4 hours, that it takes to replace the gaskets on these headers for this particular engine, this particular model, or whatever. So that's what we're going to pay you based on, is these 4 hours. Now, it could have taken you 2 hours to do the procedure or to change those headers and the gaskets, but you're going to get paid for the 4 hours. And that's how they kind of do this too. Oh, you took out somebody's appendix using, laparoscopically. Well, our rate to reimbursement is $500. Well, if it only took you 30 minutes to take it out, you essentially are making $1,000 an hour off that procedure. But let's say it was a really bad one and it was really stuck down and it took a while to take it out and it took you 2 hours to do that procedure. And you had to convert to open and all this stuff. Now you're only making, $250 an hour as opposed to $1,000 an hour. And if you're only getting paid by Medicare or Medicaid, now that 35, let's say for Medicaid, $35. If it took you half an hour, you're making $70 an hour. Good job. If it took you 2 hours, now you're making $17.50 an hour. So this is why surgeons want to do a lot of cases. They're more interested in quantity rather than time, or like a time clock, right? They don't, at 3 o'clock, they're not, okay, well, I'm done and somebody needs to relieve me and I'm going home. They're there until the work is done. And then this is how they get paid. So now you can kind of start to see why we have some of the regulations and things that we do in place, because this is the mindset of the surgeon, right? And they're one of our customers. Our main customer is the patient, but the surgeons are our customers too. They are not employed by the hospital. That's why it's a private practice. They are self-employed and contracted with the hospital. So we got to kind of do things to kind of help curtail them, because without them bringing their patients in, then we don't have work to do and the hospital doesn't make money. So you see, we all kind of like work off of each other. So it's why we also need to kind of keep those surgeons happy and coming back with patients. Now, the healthcare management and the way that it's kind of set up is up at the top. You got your board of directors, right? Those are the ones who are most responsible for everything going on in the hospital. Just below the board of directors, this is the medical staff, right? These are your doctors, anesthesia, physicians, those kind of people. These are the people who are actually going to give that patient care, right? And then just below the doctors, then now you have your administrative staff. This is your, managers, directors, charge nurses, those kind of people, right? The ones that walk around with clipboards and making sure that the things that we're supposed to be doing are getting done. Some of the positions, right? You got CEO. This is all up in the board of directors part. And then, below the CEO, you got your VP, your vice president, right? And then below the vice president, you got the director of the perioperative services. And then you have perioperative manager. Because remember, perioperative means pre-op, intra-op, and post-op all together. So that's perioperative. So that's those three components all together. So anything that's the patient's being done testing, prior to surgery, falls under perioperative. Them actually being in the OR or intraoperative, and then after going over and recovering in the PACU, uh, all the way up until they leave to go to the floor or go home. All three of those areas are perioperative, not to be confused with pre-operative. And then these three managers all fall underneath the director. Usually your post anesthesia care manager is in charge of both the pre-op side and the post-op side, because pre-op and post-op are usually in that same area. Your chain of command, for those who are military or have experience with military type stuff, you're very familiar with your chain of command, right? You got a problem, you take it to your very immediate supervisor, and then their supervisor, and you work your way up, right? That's your vertical alignment, right? We as the techs, we're pretty much bottom of the totem pole when it comes to vertical, right? Horizontally, that's kind of like nurse to nurse, tech to tech, right? You can have a little bit of hierarchy in that too, where maybe you have a tech who is the lead preceptor, or they're in charge in conjunction with one of the nurses in charge of one of the services, like they're the ortho team leader, or the GYN team leader, or general team leader, something like that, vascular, right? And their job is to make sure that all the supplies and everything are ordered and nothing's ever going to run out, right? Make sure that if there's instrumentation that needs to, specialty instrumentation that needs to be brought in, or replacements, things that broken, things like that, they're on top of that stuff. Making sure that they have, the latest and the equipment and supplies that the surgeons want. They're facilitating all of those kind of things. That's that horizontal alignment. So you can have a tech who's kind of in charge of a service and then he has team members, or she has team members underneath them that work in that service as well, but they're not the ones who are in charge of making sure that everything is running smooth. Healthcare policies. These are all things that we have in place in order to protect the patient. They have to be, like the policies on how we perform our counts, things like that. All the things that you're going to learn in the lab, in order to be a tech, but they also have to be in writing somewhere so that we can refer back to them in case there's ever a question about something. Like, oh dang, it's been a long time since we've done this particular thing. Let's make sure we're doing it right. So you go back to the policy and read up on it. Can we even be doing this and things like that. Usually, when you do your orientation, the first couple of days of orientation is like hospital orientation, and then after that, it becomes unit specific orientation. And there'll be a day that you have to sit down and read through all the policies and familiarize yourself with them. Maybe take like a little quiz on it. Something like that, just so that they can say, yes, you were given a copy of the policies, and you said that you do understand and that you will adhere to them. Right? This is all about the normal things that we do every day, but they want to make sure that you were given a copy and given the opportunity to familiarize yourself. Pre-op. Right? These are your professionals that you're going to see. That should be perioperative professionals. Obviously, you'll have a surgeon, maybe a surgeon's assistant. That could also be called a physician's assistant, or a first assist. You'll have the anesthesia care provider, or ACP. You may see it abbreviated. You've got your registered nurse, right? The RN in the room, who is specifically trained for working in the OR. Right? Then you have an LPN or a CST or a CSTFA or a CSA or a CAT. Now, all the ones listed on the left, these are all techs. So an LPN and a CST perform the same job duties. They're scrubs. You can work as a scrub in the OR as an LPN. And then you can also, obviously, you guys can get certified as a surgical technologist. That's what you guys are doing now, right? You can also be a certified surgical technologist and then go and get your certification to be a first assist. So you would scrub sometimes, and other times you would assist the surgeon up on the field. So then you could also be just an assist. So you're no longer a tech, but you keep your certification as a surgical assist, and now you work as a first assist solely. And then the certified anesthesia tech, they're the person who they assist anesthesia when putting patients to sleep. They restock their carts. They're the ones who are doing the ordering and restocking of their supplies and things like that, and getting anesthesia the things that they need, to put patients to sleep and to help keep them asleep and things like that. But this is the team. Usually in the room, you're going to have a minimum of four people: the surgeon, the anesthesiologist, the nurse, and the tech. And those are the four people that will be in the room performing the procedure. If it's a little bit more complicated procedure and the surgeon needs some help and some hands, that's where they may bring in like either a first assist or a PA. A PA is a physician's assistant, or another surgeon, right? An assistant surgeon, to help them with the procedure. And they may even also have like a mentor, because you guys will see when you graduate and you start your first job, you won't be on your own. You'll still be with a preceptor, kind of walking you through the way that facility does what they do and their expectations. The same is true with surgeons. Whenever they graduate, med school and residency and everything like that, and they're going out to be a surgeon on their own, whatever group they get hired with and things like that, one member of that group will be their mentor. And they go with them, the first few months of them doing procedures and help and watch them do procedures and stuff like that, just to make sure that they're competent and that they can be trusted to do stuff on their own. It's always like a double check, right? You've got your OR educators, right? These are the people that make sure that the OR staff is compliant with like the new technologies and the new supplies and instrumentation and things that are coming out and that we're using, so that all the T's are crossed, and then at any time Joint Commission comes to check out to make sure that we're trained up with the latest and greatest, then they can provide paperwork and evidence showing such, right? You can have your surgical orderlies or aides. These are the people that like the housekeeping that are going to help you do turnover, things like that, help maybe position patients, stuff like that, just kind of be the extra muscle around. You'll have your central processing or CPD tech. This is the person downstairs, reassembling the trays and potentially picking cases and things like that. And then patient care techs. These can be like transport techs, people who if it's a big enough facility like Advent Health South, where you have multiple buildings kind of connected to each other through like corridors and things like that. If you've got to go pick up a patient from 3 buildings away, it may be more efficient to have these transport personnel in the hospital, so that way you can now focus on getting something else, some other aspect of your job done while you're waiting for that patient to be brought, kind of thing. But not all facilities have patient care techs and transport techs and things like that. The people who can sit with patients or move them from one place to another. Like especially if I don't know how many of you have ever been a patient in the hospital, but you could be in your room on the floor and you need to go to physical therapy or X-ray or have your blood drawn, something, right? And they have to physically take you somewhere, and that's these transport techs that come and pick you up, take you to your spot because your nurse on the floor, they have like 5 or 6 other patients that they're taking care of, and they don't have the time to take out of their day and from the care of these other patients to take that patient and wheel them down to the X-ray department, sit and wait down there for them to, you know, do whatever procedure needed to be done, and then bring them back to their room because the other patients are taken care of are going to suffer because of that. So, and then you got some ancillary, tech staff. You may have a radiology tech in your room running the C-arm. You may have an EEG tech up near anesthesia who's got a bunch of monitors and stuff on the patient's head to watch brain waves. Right? You may have a medical device rep in the room if you're doing total joint replacements or you're putting in a pacemaker or something like that. There's a medical device rep there to give advice and assistance to the surgeon about their particular item that's being implanted, right? And how to best handle it or use it or what size and things like that. You can have a cardiovascular perfusionist. If you guys don't know what perfusion means, I suggest very, very much so looking that word up and understanding what perfusion means. And then that will lead you into kind of what a perfusionist does. I don't want to tell you on here because I want you to look it up. But that could be another person in the room, right? You could have an administrative person who's just watching, a risk management person, making sure that, the processes are being followed and that kind of stuff. You could have one of the facility managers in the room if you're having a problem with temperature, things like that. The COO could be walking around, just making sure things are going like they're supposed to be going. There's no issues or problems, asking questions of, the staff and the surgeons and stuff like that, how they're liking it or, what can be improved, that kind of stuff. Your director of the OR and surgical services, the board runner or the charge nurse walking around, right? And then you can have the unit secretary, the person who's like answering the phones or like even the surgery scheduler, because that's how we, book cases for the operating room is that a doctor's office will call the surgery scheduling office, talk to somebody there and say, hey, I've got Dr. So-and-so. They want to do this case on this day at this time. And then they go into their system and say, oh, I'm sorry, Dr. So-and-so already has this day at this time. You want to go at a different time that same day, or you want to go a different day, that kind of stuff. And then they also do what's called block scheduling. So when a surgeon has been coming to the same OR department, for quite some time, they offer them up what's called block scheduling and say, okay, what days do you like to do surgery? And they can say, I like to do all my surgeries on Mondays and Wednesdays. And then I have clinic on Tuesdays and Thursdays, and I golf on Fridays. Right? That's the way, that's how they've set up their life. So we'll say, okay, on Mondays and Wednesdays, we're going to block out one of our OR rooms for just you from 7:30 in the morning until 5 o'clock at night. And you call us and let us know, hey, on this day, let's say it was a Monday. So on March 29th, I've got this patient for 7:30 doing this procedure. And then at 8:30, I've got this patient and then they just fill in all that time for that room, whatever cases they want to do. And if they're, let's say, that doctor happens to be on vacation that week, they can release that block time now to anyone else who has surgeries that they want to do while that surgeon isn't using their time. But that is it for Chapter 4. I know I have a slide here for questions, and this is a video. So if you do have any questions, write them down, text them to me, email them to me. whatever, and we'll try to hit them up on the next lecture, and then we can, visit those questions and maybe get some clarification and things for you guys. I appreciate you guys sitting through this video all the way to the end. The magic word, and you're going to need this magic word so that I know that you've watched this whole video. But the magic word is essential. Essential. All right. We'll see you guys tomorrow.